Hey, that's it. That's my finish. Please call me Karen. I'll be around. I hope I speak at a kind of reasonable speed for everybody, but do wave at me. Although, from my experience so far, I think you're all very fluent in English. I'm really pleased to be here, and it makes me feel part of an international movement around women and gender equality. And that's particularly important for somebody from England at the moment, because, as you know, we're just renegotiating our relationship with Europe. So I'm absolutely thrilled to be here. My plan is to speak for about 25 minutes to give you an opportunity to ask one or two questions. And I'm briefly going to do what it says on the slide. I'm going to set the context. I'm going to give you a brief overview of the English reforms. And I've pitched that because I guess you're really interested in what's happening in Finland rather than maybe what's happened in England. So I've sort of tried to gear that towards things I think are relevant. And I'm going to speak to the impact of those reforms on women as service users and as staff, and some initial thoughts about kind of the way forward from that learning. So you're a bit bigger than we are, but we've got a lot more people. I think we've got 10 times the number of people that you have sort of squashed into that little island. And we are much more ethnically diverse than you are. So although it says on the slide 14% of the population is non-white, in fact in Birmingham that's around 48%. So we have huge diversity in our population. I think that makes us slightly different from Finland at the moment, but that I guess is changing. Women make up roughly half of the population, and the gender pay gap that we've got is broadly similar to your own. Both countries are operating in this global context where we've got a rising demand for health and social care because of an ageing population which is largely female. We have austerity, which has really hit Britain, and I'll talk to you about that because it's quite difficult to disaggregate the recent health and social care reforms from that kind of the way in which the fiscal crisis was managed by a Conservative government. There are humanitarian crises, as we know, and we've got mass migration of people, and that's obviously fueled part of the kind of Brexit debate and discussion in England. We're also at a time when notions of what it is to be a woman and what it is to be a man are shifting. And it's not as clear-cut as maybe when some of us were born. So we've got shifting notions of a kind of gender binary and a much more kind of inclusive agenda, I think, around sexuality and the trans agenda. But both countries are operating in a global context of gender mainstreaming, and I think that's really important because of the kind of Beijing platform. So there's been 20 years of developing ideas and practice around how you get some of these issues addressed. So this is about women in England. They live longer than men, but they spend more time in poorer health, and they're more likely to have unmet care needs than men. Approximately 19% are lone parents. They're more likely to be an unpaid carer, four times more likely to give up paid work to take on a caring role. And I think this will be very similar. I don't know the Finnish context particularly well, but I think if you could substitute Finland for England and the statistics wouldn't look that different. There is clear gender segregation in employment, and that plays out particularly in the health and social care workforce, with both the health and social care workforce 80% being made up of women, and women, as one might expect, tend to be in the kind of lower paid jobs. So women have a lower income across the life course, and that becomes really important when you think about health and social care reforms that are looking at maybe asking people to pay for their own care, because women are going to start off at a disadvantage. And more women than men live alone. They're also more likely to live in residential care, and that increases with age because obviously women are living longer than men. So what is the issue? What is the issue? And I think it's just really helpful, and you will all know this, to kind of set this in the context of gender shaping the different life experiences, the socio-economic realities and access to resources that women have compared with men, the way in which women express their needs for support and care can be different to men, and consequently the access into and pathways into services is different. My own area of expertise is particularly around mental health, and I'll show you a slide in a minute that kind of demonstrates some of this, but that is particularly clear in a kind of mental health context, but it's also clear in other health and social care contexts. And all that shapes the support needs and resources of women. So we need services and supports that are gender sensitive and, in some instances, gender specific. But gender inequalities are systemic. They're often ignored, and policy is often shaped by the dominant social norms. And people call that male streaming, which I kind of rather like as a contrast to mainstreaming. So just quickly, you don't need to sort of look at anything, really, apart from the green bars, which just shows the relationship between income and diagnosis of mental illness by household income in England. And this shows that women who are in the bottom 20% have much higher rates of diagnosed mental illness than either women in the top 20% or men. But I think it also shows that kind of women are always, whatever income that they're in, they're always kind of above men for those sort of health conditions. But this is, I hope it looks different in Finland. I just thought this, so this is gender and power, and this is male streaming. So Minister of State for Health, Chief Executive of NHS England. And what's interesting is we've got a devolution agenda going on where more power is being given to the regions from the national government. And this is in Manchester, where they're actually going to be delegating the budget. And this picture was taken of the 12 council leaders in 2014 that are striking up that deal. So I think your chair opened this by saying there are big issues around representation, and we've got those big time, including in universities. So very quickly, this to just give you an overview of health and social care policy in England. And I think it's really important that you kind of, I suppose that you understand that we have a Conservative government now, but we've had a Labour government previously, and before that sort of a Conservative government. Well, sorry, we had a Conservative Liberal coalition. But actually, what's happening now is a consequence of a long journey. It's not just in the last 5 years. And as you know, we have an NHS where access to healthcare was seen as a right. And I think over this period of years post the Second World War, what we've seen is health as a right, which shifted it from health as charity to maybe where we've sort of come recently, which is now health as a commodity. So you just need to think about where you are on that journey. 1997, New Labour had much more of a focus on equalities than the Conservative Liberal coalition. And I think it would be fair to say, although this is currently changing, I think, that for a period of about 4 or 5 years, gender went off the agenda. And a number of programmes that had been really trying to highlight these issues disappeared. We then had we've had a massive deficit reduction programme, and you may be aware of that, but that's had real impacts, which I'll talk about. And then we've had a recent Health and Social Care Act, which has been called a car crash in health policy in UK terms. But really what that was trying to do was really open the doors for privatisation in the market, which I think is what I've picked up some of the concerns here in Finland. I probably don't need to kind of dwell on this, other than to say that there is an increase in the role of kind of private providers, although 90% of NHS provision is still provided through the state. I think where that privatisation has happened in particular is actually in the field of social care. And health and social care are kind of separated. So you'll, actually that should say Care Act 2014, I've got the date wrong on that, but that introduced on local authorities a duty to shape the market. Now that's both a kind of threat, but it's also, I think, a real opportunity for NGOs. The other thing, and I think this is different, and probably just kind of, I hadn't realised the significance of this, and maybe is one of the differences between Finland and England, is that we have a fairly well-developed infrastructure around the involvement of people that are users of health and social care services. And the creation of Health Watch in 2012 was created as a consumer champion, but we also, in the Care Act, had the introduction of advocacy to support people with decision making. Okay, we love the NHS, more than royalty possibly. So it always becomes an election issue, and that's why we see quite a lot of change in the NHS, because often politicians come in and what they often change is the structure. So people have talked a bit about rearranging the deck chairs on the Titanic, because actually the real problems of the NHS aren't necessarily to do with the structure, they're to do with other aspects of the challenging environment in which we are operating. So these are kind of key features of the reforms, and you will pick out for yourself the things that resonate with Finland. But I think that what we've seen, and people have called this the shrinking of the state, that actually you've got the state stepping back and becoming an enabler rather than a kind of provider. And you've now seen the growth of this central role of what we call market mechanisms. So there's a market out there, which creates issues both for kind of providers, but also for people about how you choose what services to kind of access. And increasingly, people becoming responsible for their own health. So we all now wear one of these. We're responsible for kind of keeping tags on how many steps we do a day, what we eat, what we drink, etc. But that becomes, it's much broader than that, because actually health becomes almost like an individual commodity rather than a state responsibility. And tied in with that is the extension of personalisation, which is both, all of these things have a positive side to them. I don't want to be kind of overly critical, because actually the personalisation agenda for women, and we've got evidence in the UK, is actually women are using personal budgets more than men, and that when they do, they feel safer and that they feel they have more control over their life. So some of these are real kind of positives in the way that we're moving forward. But a number of things have been done in the name of austerity that are really deeply problematic. And I think I just wanted to sort of mention three things. The first is the general reduction in welfare benefits. And that's particularly had an impact on disabled people and women. And there have been kind of lobbies against it, including people in wheelchairs sort of handcuffing themselves and kind of marching outside Parliament. There's been a lack of gender analysis in the budget cuts, but although obviously there are NGOs that have then tried to do that, but a lack of analysis by government. There's been a reduction in services provided by local authorities. So local authorities in England are the organisations that provide the social care. So they're providing support to people who've got ongoing personal care needs, really, that are different from kind of health, and they will predominantly, a lot of those will be women, and we've seen overall a 40% reduction in those budgets. They're also the organisations that are giving grants to the NGOs, and so services that are relied on by disabled people and their carers and women have been cut. Alongside that, so the NHS is free at the point of access. That's why we all love it, because it's a universal service and it's free. There are elements of it for which you have to pay, as I'm sure there are in kind of Finland. Prescriptions, for example, if you have a certain income. But what's happening in terms of the social care is that the bar for eligibility for services provided through local authorities is being raised. So what happens is people are kind of being sort of squeezed out, and they will be kind of women, and I mean there's men too, but kind of people with disabilities. There have been extensive cuts to children's services. So we used to have a network of children's centres. So of course, who's going to rely on a children's centre? It's probably going to be a lone mother with children. And therefore, there has been a substantial impact on NGO services for vulnerable women. We've also seen, because in 2010, as I think you have here, we had an Equality Act. So previously, we had specific legal provisions around women, but the Equality Act made that across 9 groups, which includes people with disability, ethnicity, and one of the paradoxes of that, it's a positive in some respects because it makes the point that actually there's diversity amongst women. But one of the negatives is actually it then makes the issues for women less visible, and we've seen a reallocated provision from these groups with protected characteristics to more general services. And this is particularly domestic violence services. It contrasts slightly with the picture of the men I showed you before. So this is from February. This is a group of women activists down in Plymouth, which is actually in one of the, although Plymouth itself is quite deprived, the county it's in is actually quite well off. But in this place, they'd seen 17% cuts to local authority budgets, and so domestic violence services were being cut. Interestingly, the government, because there has been a lot of protest around this, and I think this really underlines the importance of organisations like yourselves and activism and making really clear the impact of these cuts, has then announced last November a £20 million fund. The difficulty with this is it's a fund, but it's only for 2 years. Well, domestic violence, from my experience, doesn't go away as a social problem. So women are disproportionately affected, and these are some of the reasons why. They're often their role unpaid and as either paid or unpaid providers of care. They're more likely to be service users involved in multiple forms of caring. And what's happening in this increasing gap between publicly funded services and the growing need for care services is responsibility is being transferred to informal carers, which are more likely to be women. There are also implications around the ability of women to combine paid and unpaid work. And I think just from discussions over lunch, that might be a particular issue when you've got a country where actually you've got a more dispersed geography, where you've got kind of travel that makes that difficult. And it's really clear that the impact, it's also being impacted by the ability to pay for care. And that's true for people, not just women, but people from different ethnic minority groups. So I think one of the kind of key messages is that the provision and receipt of care is deeply gendered. It's not gender neutral. 80% of the care workers are women. At the weekend, our Prime Minister, who's a woman, Theresa May, as you'll know, was brought to task about the fact that nurses in the NHS are now having to go to food banks because of the level of kind of pay. And these will be women probably who are lone parents and working in the NHS. The employment conditions of care workers, particularly in the social care sector, is really poor. We have a thing called 0 hours contract. Do you have that here? They're on 0 hours contract. My daughter, before she went to university, did a job as a care worker. She was 19. She was unskilled. She was dealing with a level of complexity, going to see a blind woman who had dementia, who was highly anxious in her 90s, but she wasn't paid either for her travel time or for any holiday time. And what we have, because of sort of migration into the UK, this sector is highly dependent on migrant labour. But this marketisation then creates uncertainty both for care workers and service users. So service users, you know, obviously you've got a workforce for which there might be a lot of turnover. And that, you know, if you're somebody like the woman I described, that's not going to kind of reassure you or necessarily provide good quality care. There's also a very low level of union representation because these are fragile kind of jobs. How am I doing for time? I can talk for a long time about this, but I'll keep going for another 5-10 minutes. Is that okay? So one of the positives about this reform is actually a recognition of kind of community assets, because if you think back to the slide I showed you, there is a real interest on prevention and a real emphasis, because there's a recognition that actually we somehow have got to stem the flow of demand for health and social care. And really, you know, we can shift the burden onto women, but we can also take a lot of action to kind of prevent the need for health and social care. And so increasingly people are interested in how things can happen within community. I mentioned the sort of positive impacts of the personalisation agenda. And there is investment in support that specifically benefits women. We often find that's constructed around their biology. So perinatal mental health provision, maternity services, both of which are important, but we need to not overlook the other issues that are important for women. And clearly, the NGOs are well placed as advocates, but also as service providers. And I think potentially this opening up of the market creates an opportunity for NGOs. So I was asked to say something about ideas about kind of moving forward. And I think I just kind of distill these really to kind of four issues, each of which I'm going to kind of talk about. But the first, I think, is really critical, is sustaining the focus on women and gender equality. Whatever the government, whatever the parliament, the focus has to remain on women and gender equality. And, you know, I think NGOs play a really kind of key role in that. There are clearly some broader issues that need attention, leadership and representation, which has already been mentioned, and closing the gender pay gap. But in terms of health and social care reform, I think legislation is really important. It's maybe not used to best effect, but in England we have impact assessments of policies and service developments. They don't go far enough and they often don't kind of translate into action. But the fact that they're there is really important because they also give us all a foothold to kind of actually monitor and evaluate what's happening. And we have to ensure that that information on outcomes is disaggregated on the basis of gender, and also ethnicity, and also disability, and also sexual orientation, so that we can really understand the impact that these reforms are having. We then have to translate mainstreaming intentions, and I think mainstreaming as a policy, I've kind of written about this, is a positive. But people have been really critical about it because it tends to be something that remains an ideal, that it's something that people in government departments do, but actually doesn't really impact into policy programmes. And I think we've got to make that leap. And then there's a big workforce development piece around this, around training, not only of health and social care staff, but I was as bold as to venture our politicians as well. I'm not going to talk about that. The second thing is we need a proper infrastructure for social care. We have to kind of recognise the changing shape of our societies, that women work, they have multiple roles, and to just expect that women can take on responsibility for social care is deeply unfair. So our government suggested that actually the way that we should have this infrastructure for social care is individual savings for older women. But as I've demonstrated, women are likely to have lower earnings. And so we had a carers commission that's actually arguing that for really a social care service that's similar to the NHS, funded through collective insurance, and that you create career pathways for the social care workforce so that actually you've got sustainable and high quality care. The third element, and I think this is probably of interest to many of you in the room, is the importance of sustaining and developing the NGO sector for all women. I don't need to tell you what a vital role you play, and both in terms of activism, which I think you have to sustain, but also in service delivery. And you bring a closeness and understanding of women's lives and experience and needs that may well be missing from government departments. I think the importance of co-producing with women who use health and social care is absolutely vital. And clearly, there's a big issue, particularly in a context of competition, around how you work together and effectively collaborate. That's just kind of something that's an organisation I really like and for you to look at if you're interested. And the fourth thing I think is really critical is that we have to constantly reflect back. We have to evaluate, we have to monitor, and we have to publicise the findings on these kind of impacts using some of the methods I've suggested. We have to look at the impact of reforms, and we have to promote alternative approaches. And that includes women-centred employment practice and women-centred ways of working. And the previous publication that I put up is just kind of quite a nice publication that does exactly that. It articulates what women-centred working means. And I can connect you with the author of that if that's helpful. So this is a more famous resident of Birmingham. I think you'll all know her. Yes. She's 20. And I suppose I want to kind of finish this by leaving you with words from your own countryman, which is the introductory statement from a lovely publication that I was given over breakfast this morning. And it just seemed to me to be sort of sum up really what the kind of journey is around these health and social care reforms, that we shouldn't get necessarily lost in the detail, although the devil is always in the detail, but that we should be bold and that we should hold on to this broader mission of gender equality for women. Thank you.
Dear Karen, thank you so much. Okay. And we can truly agree of the need of gender-specific services. We both have soon gone through the social and welfare reforms, and I think we have so many issues to speak even longer. I mean,
yes,
for hours and days even. Time flies so fast. But you mentioned like the lack of gender analysis of budget cuts. We feel share with you gender reduction of in welfare benefits. And you mentioned mainstreaming or mainstreaming.
Yes.
And the impact of mainstreaming in the governmental policies. I think we all share your visions and thoughts mentioned today. May I ask if there is a quick comment or question to Karen?
If I may, thank you, Karen. I think it was extremely interesting. I don't know about the others in the audience, but I feel that in the discussions on our social and healthcare reform, actually this gender the gender glasses have been quite absent. Mm-hmm. Or when it has been there, it has been rather on a statement level, and then sort of assuming that this is something that just is somehow accounted for, you know, and that all the the agenda is completely neutral, in a way, gender neutral. And for that, I think this kind of research is extremely helpful. Could you tell us a little bit about how the reception among politicians, is there a political debate in the UK about this? And I mean, how can it have, do you have felt that some part of this has been more understood than the other? I think we all somehow understand that elderly people are a lot women. That's something that we sort of... Yeah, and exactly. That's somehow that is taken, I think. We don't have to prove that anymore. but for other issues, for instance, this women-centered approach, how do you sort of lobby for that?
So I think that has been extremely difficult. I mean, I think when... So under New Labour, there was much a greater focus on... sorry, I can't find... I was just going to show you the slide. I can't sort of find it, so maybe we haven't got time. But there was a much greater focus on equality in general. There was particularly a focus on race equality, but also on gender equality. Women's issues now, there's quite interestingly, quite a big focus on the transgender issue or on FGM. So things that are kind of important, but actually in terms of, and I'm not a sort of utilitarian, maybe affect smaller numbers of kind of women, but the kind of broader issues have become invisibilized, I think, since 2010. So when I led a program, co-led a program around how can you get gender equality into mental health services, and these are some of the things that, you know, these were the 6 things that we kind of worked on, and you know, whether they're the right 6 things actually isn't important, but what they were doing was taking a kind of policy of mainstreaming and saying, well, what would that look like in a context of health and social care? Well, we should do these things, we should address violence and abuse, and that led to a whole range of kind of actions. I think in 2010, what happened was those organisations went, they were seen as expensive, and therefore you didn't have the development capacity that you'd had internally. So what happened was that NGOs really picked up the baton. I think they've done that well. We've now, although of course we're just about to go into an election, but we have had a Minister for Women, and that I think helps to really get some of this kind of agenda taken forward, and they've recently set up a group task force that is looking at these issues. So it's beginning to come back on the agenda, but I think that's why it's so important that people working in health and social care services at a kind of policy level, which I suppose is a lot of my experience, are working in partnership with NGOs to just keep it alive. Because I think you have to, there's such resistance, there is such resistance, or it's seen as an agenda that's been done. Oh, we've done that. Feminism has been successful. We know that's not true. So I think it's just how you keep it alive, and you just find any way you can.
Well, it's easy to move with this. Hi, I'm Hanna Kemppainen. I would be in the role of communication officer of Tasa-arvovaje, which is a project equality deficit. Also promoting, we have had researchers also from Great Britain telling about this, and it's very good to have international research, and thank you for coming. The one thing that I noted here when you said we need representation, I just read news from one magazine here that said that new persons, like leaders for the social and healthcare sector, have been nominated by inviting, and all were male. And also we're having these regional elections next month, because all the all the services that are decided, of course, have to be politically managed, and then we have the issue, how are we going to get women to participate, and how we are going to get women to be the leaders of the new services. So I would like to know, how has it been in Great Britain, and have you had any kind of like huge campaigns for women who are the ones who use the services, and also who are working in the services, really to be there presented and like encouraged? Also, this is from the perspective of research and also from the perspective of women's organizations. Thank you.
Yes, is the answer to that. I mean, I'd have to kind of do a bit of digging maybe to think about people that could kind of help you with that in particular. But there has been, this is recognised as a problem. There's a lot of senior managers, less so in social care, but particularly in the health sector, are men. They're more likely to be men, but the bulk of the workforce is, you know, likely to be kind of women, as I've described. So there have been programmes around what's called leadership development, so to encourage women to go into managerial posts, or you know, to take up kind of leadership roles. So it is shifting, and it's shifting within our parliament as well. So I think we now have, I think it's 22% of women are MPs. I hope that's right. But that compares with 8% when we had Margaret Thatcher as a Prime Minister. And that differs by party as well. So the representation in the Labour Party is, paradoxically, because we have a woman Prime Minister, is greater than in the Conservative Party. So it's recognised as a problem, which is the first step. And yes, there is investment in development programmes. But actually, the extent to which those involve women that are service users, which I think is kind of critical, is a bigger challenge. I think it's one that's really important to kind of hold on to. And I got a sense when I was talking over lunch that there is a lot that's going on around trying to change the dynamic between the state and people that use services. So there's a huge emphasis on kind of what we call co-production, about trying to make those relationships generally more equal. That hasn't tended to particularly have a gendered kind of dimension to it, because it's kind of across the board. So I think that's a challenge for us as it is for you.
Okay, thank you, Karen, so much. I mean, we have many MPs with us here today, and we truly agree that the importance of female leadership in the government and parliament as well. Thank you so much. And I think we are having tomorrow a lunch together. Any one of you who is still interested to discuss further with Karen, you're welcome to join us. Thank you so much.